story forward now. The World Health Organization says the AstraZeneca COVID-19 vaccine has shown efficacy against severe diseases to prevent hospitalization and death. This comes as a recent study revealed that there was minimum protection in mild to moderate infections of the 501YV2 strain, which was first identified in South Africa. Government has halted the rollout of the vaccination program to better understand how the vaccine reacts to the locally found strain. The chairperson of the Ministerial Advisory Committee on COVID-19 vaccines, Professor Barry Schoub, and of course joins us on the line right now via Zoom. Thank you so much for coming through.
Thank you very much for having me. Thank you.
All right, so let's just understand firstly, as laying the ground for our discussion here, like AstraZeneca can work in certain circumstances, but it's being rejected in South Africa. The reason has been that there hasn't been any convincing case scientifically that it can do that job in as far as helping to cure or prevent COVID-19. What do you say about that?
Yes, thank you. I think the problem is that we just lack the data, the evidence that it is going to be effective. We did have some worrying signals that came from the laboratory. Now, we looked at people that recovered from the first wave, was the previous strain, and there was very little protection or very little neutralizing ability in specimens from that first wave. So in other words, if you're exposed to the first virus, you're not going to be protected according to the laboratory science against the new variant. We then looked at various sera and from, in other words, blood specimens from people that had been vaccinated with various vaccines. And again, in the laboratory, the signals were not very good. The problem is, of course, we needed to kind of find out from people that had been vaccinated whether they would be protected against a variant. In other words, this 501Y2 variant, which is a dominant strain in our country at the moment. The problem is that the only trials that have been done, or the only people that have been vaccinated who are exposed to that, are the people who are part of the trial. And that's relatively small numbers, number one. And also it is people that are fairly young and unlikely to get severe disease or land up in hospital. So at this stage, we just simply don't have the data of whether it is going to protect against severe disease or hospitalization. It may well do, but we just simply at this stage don't have that data. What we do have data for is that it doesn't seem to be very effective in protecting against mild or moderate disease. And because of that, we decided, look, at this stage, let's suspend using the AstraZeneca vaccine until we get more evidence of its efficacy. And there is a lot of research going on to try and get that evidence or see if we can use the AstraZeneca vaccine in other ways. In other words, as part of a 2-dose schedule, for example, with another vaccine. That's just one option which is being looked at. But the bottom line is to suspend at the moment and to instead using AstraZeneca, use one of the other vaccines, such as the Johnson & Johnson, to start with the rollout with our healthcare workers.
Now, Professor, the dogma here is that when a country has been caught off guard in terms of research that was done in the season of trying to cope with the infection rate of COVID-19, and when the vaccine arrives, then one gets to find out that it doesn't have efficacy. Well, I get it from 80% to 22% regarding the variant. Surely then one will have to ask the question, do we need a different set of vaccines to deal with the various stages of these mutations?
Absolutely. I think this is it. This variant was completely unpredictable. I don't think anybody really foresaw that we would have a variant arising which would escape completely, or not completely, but certainly very, very significantly, the effects of the vaccine that we had. The vaccines were in fact very effective, for example, in the Northern Hemisphere, where they don't have this particular variant. And all the indications were, despite the fact that in the laboratories there were worrying signals, but in the field, in other words, in human beings, because we do have a complex immune system, that it would be effective. But we could only really analyze this data very, very recently. And this data that it wasn't so effective only came out, in fact, last week. and only then can the decision be taken, which is what we took.
Can you help us to crisscross COVID-19 throughout the world? When it erupted in China, the outbreak spread throughout the world to different continents. So when there is a mutation, the variants, they are now called South African variants, and in the UK, they are different. The variant is different from our countries. How do then we say that a vaccine can work in Europe but cannot work in South Africa? How would you characterize the immune systems of different areas and continents in the world in terms of their response to what different types of vaccines or the same vaccine for the same virus before it mutates?
Yeah, look, these mutations occur spontaneously. They are driven by the immunity in the population, which allows the virus to multiply. And the virus will develop these mutations in order to escape from the effects of the vaccine, in inverted commas. Viruses, of course, don't think, but it will be a spontaneous mutation which will give the advantage of the virus in the environment of the vaccine. Now, what has happened, we got a very good genomic surveillance system. In other words, a system which can pick up these mutations and pick up the variants. It's very well developed. We've got excellent scientific resources in this country. And I think it just so happened that the excellent surveillance was able to pick it up in South Africa. We actually don't like calling it a South African variant because it's not really a South African variant. It's a 501v2. It's a bit of a mouthful, so it's easier to say South African variant. But this particular variant might well have arisen somewhere else in another country which doesn't have that surveillance. It just so happens that we do have the surveillance and it was picked up here. Now, in the United Kingdom, they also have a similar, but not exactly the same variant that we have. It's also a 501, but it doesn't have the additional mutations that we have, the 484 and the 417. And it's those additional mutations which give the virus the ability to escape from the vaccine. In the United Kingdom, they haven't shown that yet. Their mutation does spread more rapidly, but not that it escapes from the vaccine. There is a variant which is very similar to ours in Brazil, and that one does have this 484 variant and will display much reduced efficacy of the vaccine. So it just so happens that this virus is constantly changing, and depends where you actually pick it up. Some countries have very good surveillance like we do. United Kingdom has good surveillance, but even the United States, Dr. Fauci, who's the main spokesman for infectious disease in the United States, he's been complaining that they don't have good surveillance in the United States, which is a very well-developed country. So that variant may well be there. However, now they are picking up that this particular variant, our 501v2 variant, is being picked up in various countries around the world. It's been found in United Kingdom, for example. It has been found in the United States and in various other countries as well.
So now let's get into the Johnson & Johnson vaccine. How much do we know about it, and how does it differ from the one that has been put on hold now?
Well, the actual construction of the vaccine is similar, but the actual part of the virus that they engineer into the carrier is another virus called an adenovirus. That part is a little bit different in the Johnson & Johnson one to the one which is put in the AstraZeneca vaccine. And that may account for the fact that the Johnson & Johnson seems to be a better vaccine in terms of neutralizing the variant virus, this particular 501v2 virus. So that's the one difference. The other difference, of course, is that these vaccines, although they do have a similar platform, a similar structure or way that they're produced, there are differences in different manufacturers. And it just so happens that the Johnson & Johnson one does seem to work a lot more effectively. The other thing is this: we have to remember the Johnson & Johnson vaccine is that that has been trialed, it has been examined in trials in South Africa with the variant. So we do have the data that the Johnson & Johnson does protect, first of all, against mild to moderate disease to quite a significant extent, and certainly for severe and hospitalized level disease as well. So we do know that Johnson & Johnson does work. And that's why you want to substitute at this stage, this early stage, until we find out whether the AstraZeneca will do the same.
So when it comes to the shelf life, as it would take quite some time to vaccinate millions of people, how much do we need at the initial stage, as this has been piloted from the volunteers who went for vaccination? And even if we don't know their names and we cannot interview them about how they're feeling now, if there were any side effects, and whether or not they would recommend anybody to take a vaccine now, because members of the public would want to know information, and honestly and transparently so. What does one do then when it comes to the efficacy of this Johnson & Johnson, and what kind of a confidence booster can be provided to members of the public to say that, yes, the government blundered by actually not doing their homework with AstraZeneca, and what can they do then when Johnson & Johnson is being recommended and being put on their table?
No, that's an excellent question. What I can say is this: what the public can be reassured that we have such an excellent, in-depth scientific expertise in this country. We're very lucky. The science in this country and the scientists are of a very, very high standard, a very, very high international standard. And in fact, it is the science which actually detected these variants. You know, we'd be in a very sorry state if we didn't have that level of scientific expertise which did pick up the variants. And also now we have the excellent science which did very, very good trials, clinical trials, to show that it doesn't work in human beings. So again, I think the public can be reassured because that science was able to pick up these variants, which in many other countries they haven't done. We have got a very deep foundation of scientific knowledge, which can, first of all, assure the public that the vaccines which will be used will be vaccines which are effective, and the vaccines which will be used will be safe. And also we've got a very, very good, excellent, a very rigorous regulatory body called SAPRA, the South African Health Products Regulatory Authority. And they are very, very stringent in what vaccines they will allow in terms of safety and in terms of efficacy. They will only allow those vaccines which are proven to have an excellent track record of both safety and efficacy.
Let me pick your brain on something very interesting that I picked from a South African journalist who's based in Boston in the United States. Charlene Smith was asking about the issue of, you remember the statements that were made by Donald Trump, who was saying that COVID-19 is a Chinese virus. But then, you know, when you pick up from the UK virus, and then you have to refer to a mutation in South Africa as a South African variant, and you just mentioned Brazil now. So, you know, the description of the variation or mutation of the virus can be regional, or tropical, or whatever region. So would you say that it's wrong to mention it according to its region or origin of country? And what about the Spanish flu?
Well, you know, you're given one example. The Spanish flu really had nothing to do with Spain. It actually came from the Far East. But in any event, yeah, you're absolutely right. You know, they talk about the South African variant, they talk about the Brazilian variant, and they talk about the United Kingdom variant. And it really is very unfortunate because it actually puts a stigma on that particular country. And we in South Africa have actually felt that because now we're being, to some extent, I won't say victimized, but selected in terms of travel and travelers and so on. You know, we in our committee, we never say South African variant. We always call it the 501YV2, which is a scientific name. It's position 501 in the genome. Y is a substitution of the amino acid. V2 is version 2. V1 was the United Kingdom one. So that's what we talk about in our scientific communities, 501V2. There's another terminology called B1351, which the British scientists like to call it. So at the moment, it's a little bit of a confusion. You know, it's much easier to say South African variant or Brazilian variant. But the World Health Organization, they are now having discussions to actually give these technical names, which are easy for non-technical people to say. For us, it's easy to say 501YB2. But if you're not in the technical field, sometimes, if you're not in that field, sometimes it's a bit of a mouthful.
All right, so now let's have a parting shot. There were South Africans who were very, very skeptical about taking a vaccine, and others were saying that it can, manipulate DNA and so forth. But right now, they want the vaccine. Others are rearing to go because they say if there's vaccination and we have the infection rate dropping, it means we can have our lives back. We can go to level 1 and move on with our lives. So what is your outlook? And of course, I just want to, get you on your crystal ball. How do you expect this vaccination process to pan out from the initial stage, the middle stage, and the end stage?
The problem, and it is a challenge, because as you pointed out, there is a substantial proportion of our population in various sectors of society who are asking very legitimate questions, very understandable questions. People are nervous, understandably. This is a new vaccine, it's a new virus, it's a new program, and they want the facts. I think that's the majority of people that are hesitant about taking the vaccine. You do get the anti-vaxxers, but I think they believe in all kinds of conspiracy theories, and we just need to point them to the right sources of information. But the majority are just a little bit nervous. They kind of want to know, are there side effects to the vaccine? How long does the immunity last, etc., etc. I think a large number of those individuals, once they see their family, their friends, their neighbors being vaccinated without any problems, and now they at least partially immune, if not totally immune to the vaccine, they will then also fall into line. I think many will. The others, it is really our responsibility, and with respect also your responsibility as the media, to actually convey that information to the population appropriately, to the different sectors of our population, to explain that the vaccine is so safe now, particularly with the 21st century science, which we got, and also in our country in particular, but in the world generally, to reassure them that the safety levels of vaccines today are so high, and they have to be, because we're giving them to healthy people. It's not like medicines which you give to sick people. These are given to healthy people. So our standards are going to be extremely high. These are very, very safe vaccines. They've been rolled out in millions overseas with very, very little problems, very little safety problems. So we can reassure the public that it's not going to affect your DNA, there are no microchips in it, etc., etc. These vaccines undergo very, very rigorous safety evaluation, all the way from the trial stage, all the way till where it's licensed, and after licensing as well. And the public can be reassured on that score.
Yeah, well, surely one could say that there are some people who have the guinea pig phobia, and they don't want to be the first ones. They would join in later. But we're going to have to leave it there. Thank you so much for making time to speak to us, sir.
Thank you for having me. Thank you very much.
Yeah.
Good. Have a good afternoon.
All right, that's the Chairperson of the Ministerial Advisory Committee on COVID-19, Professor Barry Schoub, speaking to us right now, right here on SA Today, about South Africa expecting to receive a batch of the Johnson & Johnson vaccine.